All right, we are talking with Dr. Hohler, who recently joined Northern Westchester Hospital, and her exact title is the Regional Lead for Neurology for all of Westchester County. She's the Chair of Neurology here at Northern Westchester Hospital and the Chief of Neurology at Phelps. Today we are talking about Parkinson's and MS, and you classify them as movement-related disorders.
Mm-hmm.
Okay. So how far in advance can someone begin to see symptoms of Parkinson's or MS?
Well, Parkinson's disease in particular is a very complex disorder that involves not just the brain but the body itself. And so we believe that Parkinson's symptoms may manifest early, 10 years even before motor symptoms, with things like constipation, sleep disturbance, and in particular, something called REM behavior disorder, where people act out their dreams.
I've heard of that.
And so those are often early markers. And actually, a lot of collaborative work that we do now for neurology is actually working with the sleep doctors, either in neurology or pulmonology, and to identify any individuals who might have REM behavior disorder to refer them to us so that we can monitor them. And then in terms of constipation, while we don't have a lot of necessarily great collaborative work at this time that we do with the gastroenterologist or primary cares around that, it is something that we recognize when patients come to see us with their motor symptoms, for example, their tremor or their gait difficulties, that yes, they've suffered from constipation for years beforehand.
And untreatable, or they're just not going and getting it treated?
So oftentimes people start to just kind of get used to their constipation. And so what we aim for is a daily bowel movement, but a lot of the patients that come to us initially usually have a bowel movement every other day, every third day, sometimes not for a week.
Wow. What are the early symptoms that you see in Parkinson's and MS as well?
So for Parkinson's disease, the motor symptoms are a tremor, which is typically a resting tremor, and we call it a pill rolling tremor, so typically mostly involving the thumb portion of the hand. Oftentimes that first affected limb can be stiffer, slower. When people walk, they might have an arm swing on the affected side. They can have difficulties with the balance and their gait as well. And then, as I mentioned, when we do the history taking, we find out that they may also have had sleep difficulty, constipation issues. And then the later stages of Parkinson's disease often are characterized by issues with mood, issues with cognition, and issues with blood pressure regulation, typically blood pressure dropping when people stand up, which can be very difficult. With multiple sclerosis, also, oftentimes there's a delay in diagnosis. Symptoms can be, people can present with vision loss, they can present with numbness or weakness in parts of their body. Oftentimes it is worse after exercise or in the heat. And so people often are diagnosed after having these types of symptoms on hot days.
Okay, interesting. You mentioned the tremors with Parkinson's. So what's the difference between a Parkinson's tremor and an essential tremor?
So it looks different. Parkinson's tremors, or the rest tremor, typically starts on one side and then moves to the other side of the body. Typically involves stiffness and slowness and the walking difficulty. Essential tremor is typically a postural and action tremor, usually involves both hands. When the person is trying to do something like write, pick up things, for example. It is very commonly familial. So essential tremor, 50% of people or more have a family history of essential tremor. You can also have a head tremor, most classically a no-no tremor associated with essential tremor. You can also have a voice tremor associated with essential tremor. Those are less common with Parkinson's.
Tell me a little bit about the different types of Parkinson's.
So there is an umbrella category here again called Parkinsonism. And underneath that, you have something called idiopathic Parkinson's disease, which is our traditional Parkinson's disease, which is by far the most common. You can also have some Parkinson plus syndromes, one of which is called Lewy body dementia. And that actually is characterized by cognitive issues very early on in the course of the disease, typically within the first year of diagnosis. And typically those people can suffer from visual hallucinations early on as well. There's another type of dementia called vascular dementia, and that's often seen in people who have other vascular risk factors like hypertension, diabetes, high cholesterol, and that's characterized by stroke-like symptoms and stroke symptoms, and then a cognitive decline as a result of that. Those are by far the more common. People can also have Parkinsonism related to infections. They can have Parkinsonism related to vitamin deficiencies, et cetera. So Parkinsonism is, again, the umbrella.
Is the tremor, the hand tremor, always part of the diagnosis?
So the tremor is most common with idiopathic Parkinson's disease. You do also typically see it with Lewy body. Lewy body often has more symmetric symptoms early on. And then with the vascular Parkinsonism, the tremor is less common. Typically the gait is more affected earlier in that process as well.
Can you explain what testing is done, especially because these different types, right, it's not all starting with the same symptoms, so it's not such an easy diagnosis. So how do they test?
Yes, so the most important first step is a neurologic exam, which is a very comprehensive test. So we sit down with our patients, typically for half an hour to an hour, and we go through, number one, all of the history of their symptoms, when they started, and we ask all of those detailed questions to try and get some of these pre-diagnostic symptoms to the current day. In addition to that, we ask about family history, exposures, risk factors, those types of things. And then we do a very detailed neurological exam, which involves cognitive testing, testing of special senses, motor and strength testing, testing of tone in the body, testing of coordination, and testing of gait and balance. Very, very detailed tests. And that allows us to localize the lesion, as we call it, so we can determine whether or not this appears to be something coming from the brain, something involving the whole body, and then gives us an idea about what the diagnosis may be. We then can do some confirmatory testing, whether it be imaging testing to help rule out some of the other causes of Parkinsonism, or specific testing to look at dopamine levels in the brain. We may also then do other types of testing. So nowadays there are some more advanced blood and spinal fluid markers for Parkinson's, looking at the Lewy body, which is a pathologic marker of Parkinson's disease.
And so is it common to go through all those various levels of testing in order to get the diagnosis? Or if you're able to quickly see it after you've sat down with them for a half hour and maybe done a couple of the other tests, do you go the route of the scan and the blood? And
it's a great question, and it depends on the individual and what symptoms they're manifesting with. A good movement disorder doctor can diagnose a patient with Parkinson's in the waiting room if they have several of the symptoms. So it has been a clinical diagnosis for many, many years, and we are still able to do that. But if there are questions, concerns, and also to help confirm the diagnosis, we have all these additional tests.
Got it. You briefly mentioned a couple of the causes, so I want to get into that a little bit more. Are the causes mainly genetic, or are they environmental based, or is it a combination of both?
We believe that most cases are a combination. We know from our genetic testing studies that we've done that 13 to 15% of people have a known genetic marker. Right now we have several known genes associated with Parkinson's disease. More are likely going to be found. But in addition, we also have great information about environmental causes for Parkinson's disease, whether that be toxins in terms of related to water toxicity with heavy metals, paraquat in terms of farming, jet fuel exposure, Agent Orange exposure in our vets, or dry cleaning exposure, et cetera. We know that the environment also is associated with contributions to Parkinson's. It is likely that those who have genetic and environmental risks are going to be manifesting it likely earlier in the lifespan than those who might just have an environmental exposure that's mild, for example.
What's the average age of diagnosis?
Most people are diagnosed with Parkinson's between their 60s and 75. And there's a slight increased rate of men to women. Right now, there are 1 million people in the United States with Parkinson's disease. 90,000 are diagnosed each year, and there's 10 million worldwide right now. We do think the incidence of Parkinson's diagnosis is increasing, and a lot of that related to our environmental toxins.
Could it also be related to better diagnostics?
Likely some component of it, but probably not at the rates that we're seeing.
Okay. There are medications like, I'm going to mispronounce this, levodopa, thank you, that some people say can wear off over time, that work really well, but can wear off over time, and other people say that that's not the case. Where do you stand on that, and why?
So the research shows us that the Parkinson's disease medications help to supplement the dopamine in the brain. The issue with patients with Parkinson's disease is that their dopamine levels continue to decline over time. So when somebody is clinically manifesting motor signs, they've already lost likely 80% of their dopamine cells. The medications that we're providing them either help to directly or indirectly increase dopamine levels in the system. The issue is that over time, those doses need to be increased to compensate for this decline. So the dose that you get started on for your Parkinson's medications is going to be different than 5 to 10 years because your disease is progressing.
Got it. So it's not that they don't work, it's just that the dose has to continually
Be adjusted.
increase.
In most cases, it's increasing, but then at some points things stabilize, and sometimes people get side effects to medications, and so it needs to be reduced.
Is it something where levodopa may or may not be as effective for one person and they would have another option, or is levodopa the go-to?
So carbidopa levodopa is the gold standard in terms of most effective, but there are a number of different other treatments. So there are a group of medications that act like dopamine or the dopamine antagonists, and there are medications that help to decrease the breakdown of dopamine. So those are called MAOB inhibitors and CAOMT inhibitors as well. So oftentimes we're using something called rational polypharmacy, where we're using small bits of each of these different types of medication to overall globally improve the dopamine levels in the system. Much like a diabetic might use different types of formulations, insulin and then other types of therapies to try and stabilize their insulin levels. Their glucose levels.
One of the other stories we're doing in this issue is on the organization called Ping Pong Parkinson's.
Yes.
Which we just learned was actually founded right in this area. So how does something like that, how does ping pong help with Parkinson's?
So there's been a lot of research on exercise, cognitive and physical, with Parkinson's. And the reason is that early studies that were done showed that dopamine levels stabilize or even improve in patients who participate in what we call these high intensity activities. So initially, a lot of energy was put into boxing, not non-contact boxing, because it's very complex in terms of the different types of combinations. It involves balance, it involves arms and legs. And then along with that, a lot of dance exercise, pedaling, so biking exercises, and more recently things like ping pong have also been included. Ping pong also has a lot of visual stimuli, and so that actually increases the areas of the brain that are activated with that type of exercise. It involves quick movements, just like the boxing does as well. So fast twitch muscles, along with the slow twitch balance muscles, and the cognitive processing, all of those things cause a significant higher level of networking in the brain.
Very interesting. Do you view Parkinson's as a life-halting disease?
I don't view it as a life-halting disease. I view it as a chronic disorder, and I usually talk to my patients about how it's very similar to diabetes. When I give my patients their diagnosis of Parkinson's, what I want them to do is work on their lifestyle, work on their diet, work on their exercise, and then I do a little work with them on the medication. But a lot of the work needs to be done by them. And we have a partnership, and the more we work together on that partnership, the better they do. And if they think of it as something like having diabetes that they're going to have forever, but that there are ways that they really can have an active role in optimizing their quality of life, we find that there's a much higher level of hope, enthusiasm, and those things really contribute to improving the long-term outcomes. When I first got into this field, people who were diagnosed with Parkinson's had about 5, maybe 10 years of good quality life. Now it's more like 20 to 30 years. So somebody diagnosed in their 60s with Parkinson's disease, in most cases can live a normal lifespan, and our job is to give them all the quality.
Anything I didn't ask about Parkinson's?
I think that the more we learn about all of these neurodegenerative disorders, the more we understand that early prevention, lifestyle aspects are very important, and then getting a routine that's manageable and achievable, and then having good communication with their family in terms of family support and their providers can really help them to have a successful relationship with their bodies.
Thank you.
My
so
pleasure.
much.